Good evening, and welcome. Tonight we delve into an exceptionally sensitive and multifaceted issue, the prescription of psychiatric medications to children and adolescents. It's a topic that sits squarely at the intersection of medical necessity, developmental psychology, and profound ethical considerations. We navigate the delicate balance between the potential for therapeutic relief and the significant concerns surrounding the long-term impact on young, developing minds. Joining us to dissect this complex subject are two distinguished experts with considerable experience in the field. Dr. Evelyn Reed, a respected child psychologist known for her cautious approach and emphasis on psychosocial interventions, and Dr. Ben Carter, an experienced child psychiatrist who often works with children requiring pharmacological treatment. We anticipate a robust, insightful, and above all, respectful exchange of perspectives. Dr. Reed, perhaps you would begin with your opening statement.
Thank you, Aisha. I approach this subject with considerable gravity, driven by a mounting concern over the escalating rates at which psychotropic medications are being prescribed to our youth. My primary apprehension stems from the fundamental reality of neurodevelopment. Childhood and adolescence represent periods of unparalleled brain plasticity and maturation. Intervening pharmacologically during these critical windows carries potential risks for long-term, possibly irreversible, alterations to neural architecture and function that we do not yet fully comprehend. Crucially, for many medications commonly used in pediatric populations, we lack comprehensive, longitudinal safety data spanning decades, which is precisely the time frame relevant to lifelong outcomes. Consequently, I advocate strongly for a rigorously implemented hierarchical treatment model. This necessitates the mandatory exploration and exhaustion of evidence-based psychosocial interventions, cognitive behavioral therapy, dialectical behavior therapy, family systems therapy, robust school support, before medication is even contemplated. Exceptions should only be made in demonstrably acute psychiatric crises, where immediate safety is paramount. Furthermore, we must acknowledge the inherent complexities and potential for diagnostic ambiguity in childhood. Symptoms often manifest differently than in adults and can frequently be transient developmental phenomena, or, importantly, direct responses to environmental stressors like trauma, family dysfunction, or academic pressure. Are we consistently distinguishing deep-seated psychiatric disorders from understandable reactions to adverse circumstances before resorting to medication? There is a palpable risk of iatrogenic harm, inadvertently causing problems through medical intervention, if we medicalize what are essentially psychosocial issues. We cannot ignore the potential influence of external factors either, including pharmaceutical marketing and societal pressures favoring expedient solutions over more labor-intensive therapeutic work. Therefore, implementing sensible restrictions on prescribing these potent medications to children isn't about denying care. It's about enacting a crucial safeguard, prioritizing non-invasive approaches, and protecting the long-term developmental trajectory and well-being of vulnerable young individuals.
Thank you, Aisha and Dr. Reed. While I wholeheartedly concur that prudence and caution are indispensable in pediatric psychopharmacology, I must firmly assert that psychiatric medications represent an essential, often life-altering tool for a significant subset of children and adolescents. To advocate for overly broad restrictions risks denying effective treatment to young people suffering from severe and debilitating conditions. Consider, for instance, early-onset schizophrenia, severe obsessive-compulsive disorder, treatment-resistant depression with suicidal ideation, or profoundly impairing attention deficit/hyperactivity disorder. In these circumstances, appropriately prescribed medication is not merely helpful. It can be fundamentally necessary to stabilize a child, enable engagement in therapy, prevent hospitalization, preserve educational trajectories, avert social catastrophe, and, in the most tragic cases, prevent suicide. To withhold such treatment based on generalized concerns can constitute a form of passive neglect, allowing preventable suffering and long-term functional impairment to take root. The diagnostic process undertaken by competent child and adolescent psychiatrists is far from cursory. It involves comprehensive evaluations, often spanning multiple sessions, incorporating developmental history, multi-informant reports, parents, teachers, child, standardized rating scales, and meticulous application of established diagnostic criteria like the DSM-5 or ICD. We are trained to differentiate normative developmental challenges from pathological states requiring intervention. Crucially, medication is seldom, if ever, conceptualized as a standalone magic bullet. Best practice dictates its integration within a comprehensive, multimodal treatment plan, frequently enhancing the child's capacity to benefit from psychotherapy, behavioral interventions, and educational support. The notion of widespread reckless prescribing, while perhaps a convenient narrative, doesn't reflect the ethical obligations, stringent regulatory oversight, and careful, individualized risk-benefit calculus that conscientious clinicians undertake daily. Therefore, while vigilance is vital, blanket restrictions would ultimately obstruct access to necessary medical care, disproportionately harming the very children whose conditions are most severe and who stand to benefit most profoundly from timely pharmacological intervention.
Dr. Carter paints a picture of meticulous diagnostic rigor, and while I commend that ideal, I question its consistent attainability across diverse clinical settings. Systemic pressures, such as limited consultation times, inadequate access to comprehensive assessment tools, and variability in specialized training, particularly outside major centers, can compromise the depth of evaluation he describes. My concern persists regarding the long-term sequelae. You speak of risk-benefit analysis, but how can we accurately weigh benefits against risks when the full spectrum of long-term neurological, endocrine, and metabolic risks associated with early exposure remains substantially uncharted territory? The knowns of the benefits are often short-term symptomatic relief, while the unknowns of the risks stretch across a lifetime. Furthermore, I challenge the perceived necessity of medication in many less severe, borderline presentations. Are we sufficiently exploring and addressing underlying psychosocial determinants, unresolved trauma, challenging family dynamics, inadequate school support systems, which medication, by its very nature, cannot rectify? Let's not downplay the tangible burden of side effects children experience: weight gain leading to metabolic syndrome, sedation impacting learning, potential for emotional blunting affecting social development, and in some cases, increased agitation or even suicidality. These are not trivial inconveniences. They profoundly impact a child's quality of life and developmental course. Before accepting medication as standard, particularly for moderate conditions like anxiety or ADHD, I believe we require far more robust, independent evidence demonstrating its clear superiority over sustained, high-quality, non-pharmacological interventions, not just in the short term, but over the long haul.
Dr. Reed raises valid points about systemic challenges and the importance of psychosocial context, which I fully acknowledge. However, it's crucial to understand that psychosocial stressors and underlying neurobiological vulnerabilities often coexist and interact. One does not necessarily negate the other. A supportive environment is vital, but it may not correct a fundamental neurotransmitter imbalance implicated in severe depression, or ADHD, for example. Regarding side effects, yes, they exist, and responsible prescribing involves anticipating, monitoring, and actively managing them. This includes regular physical health checks, dose adjustments, or switching medications if necessary. Crucially, the potential adverse effects of medication must always be weighed against the often devastating and far-reaching adverse effects of the untreated psychiatric illness itself. Academic failure, social isolation, family breakdown, self-harm. The argument about a lack of long-term data can be overstated. For established medications like stimulants or certain SSRIs, we do possess multi-year safety and efficacy data in pediatric populations. Furthermore, pharmacovigilance systems are continuously monitoring for emerging long-term signals. We don't operate in a complete vacuum. We must guard against a form of therapeutic nihilism, where the fear of hypothetical future risks prevents us from using established, effective treatments to alleviate definite present suffering and dysfunction. It's a disservice to children experiencing profound distress. I reiterate, medication is not a first-line treatment for mild difficulties, but for conditions where the clinical indication is clear, the evidence supports its use, and the potential benefits demonstrably outweigh the carefully considered risks.
Thank you both for those compelling points. Let's delve deeper. Dr. Reed, you advocate for restrictions. What specific forms should these take? Should they be age-based, perhaps prohibiting prescription below a certain age for specific drug classes, or diagnosis-specific, ruling out medication for milder conditions? And critically, how would such restrictions be implemented without exacerbating existing disparities, given that access to specialized evidence-based therapies varies enormously by geography and socioeconomic status?
That's a crucial consideration, Aisha. Restrictions shouldn't be monolithic, but nuanced. Perhaps mandatory second opinions from specialists for prescriptions under a certain age, say 6 or 8, or for specific potent medications like antipsychotics. Stricter criteria could apply for conditions where psychosocial interventions have shown strong efficacy, mandating documented trials of therapy first. Regarding access disparities, that highlights the urgent need for systemic investment in universally accessible, high-quality child mental health services, including therapy. Restrictions must be coupled with resource enhancement, not exist in isolation.
Dr. Carter, turning to you, how can the field better safeguard against medication being used prematurely or as a substitute for therapy, especially in primary care or resource-limited settings where specialist access is difficult? And what mechanisms can further strengthen the informed consent process, ensuring parents, and age-appropriately the minors themselves, fully grasp the risks, benefits, and alternatives?
Excellent questions. Strengthening safeguards involves several layers. Enhanced training for primary care physicians on screening, initial management, and crucially, when to refer to specialist care is paramount. Developing clearer, evidence-based clinical pathways that emphasize psychosocial interventions first, where appropriate, can guide decision-making. Telepsychiatry can bridge geographical gaps, providing specialist consultation support to primary care. For informed consent, standardized, easily understandable information sheets, dedicated time for discussion, exploring patient-family values, and periodically reassessing consent as treatment progresses are all vital. Utilizing decision aids could also be beneficial.
A question for both of you now. What do you see as the appropriate division of labor between primary care physicians and specialists like yourselves in initiating and managing these medications?
Ideally, initiation, particularly for complex cases or younger children, should rest with child psychiatrists or developmental pediatricians after comprehensive assessment. Primary care can play a vital role in screening, ongoing monitoring for stable cases under specialist guidance, and managing comorbidities, but perhaps not initial prescribing of more complex agents.
I largely agree. Specialists are best equipped for diagnosis and initial treatment planning. However, given access realities, well-trained primary care physicians, potentially with integrated behavioral health support or consultation liaison, can manage less complex cases like uncomplicated ADHD following established guidelines, ensuring continuity of care. Clear protocols for co-management and referral are key.
Another challenging area is off-label prescribing, where a drug is used for an age group or condition for which it lacks official approval. How should this be addressed? Is tighter regulation needed?
Off-label prescribing is sometimes necessary in pediatrics due to the historical lag in dedicated drug trials for children. However, it demands even greater caution. Stronger evidence justification, e.g. based on adult data or case series, meticulous documentation, and very thorough informed consent discussing the off-label status explicitly. More incentives for pediatric drug research are needed, rather than simply banning off-label use, which could deny potentially beneficial treatments.
While I understand the rationale Dr. Carter presents, the prevalence of off-label use is concerning. It underscores the data gap I mentioned earlier. Increased transparency, perhaps through registries tracking off-label use and outcomes, and significantly more investment in pediatric trials, are non-negotiable to ensure safety. Regulation should perhaps focus on ensuring it's truly a last resort after labeled options and therapies are exhausted.
One final point in this section: considering adolescent autonomy. How should disagreements be navigated when a mature minor consents to or refuses medication, but their parents hold the opposing view?
This is ethically complex. Legally, parents usually provide consent, but clinically, the assent of a mature minor is crucial for treatment adherence and success. Extensive family discussion, mediation, exploring underlying reasons for disagreement, and sometimes seeking ethical consultation are necessary. The adolescent's perspective must be given significant weight, commensurate with their developmental maturity.
I concur. The principle of Gillett competence, or mature minor doctrine, is relevant. It requires careful assessment of the adolescent's understanding. If a mature adolescent refuses, particularly if concerned about side effects or preferring therapy, their view deserves profound respect and exploration, potentially favoring less invasive options first, even if parents disagree. In closing, my position remains anchored in the inherent vulnerability of the developing brain and the principle of, quote, primum non nocere. First, do no harm, particularly when considering interventions with potentially lifelong consequences. We must systematically prioritize and dramatically enhance access to evidence-based, non-pharmacological interventions. These should form the bedrock of child mental health care. This necessitates a paradigm shift towards holistic, preventative models that address the child within their family and community context. Stricter, nuanced guidelines for prescribing, coupled with substantial investment in independent, long-term research, are not optional. They are imperative. Let us exercise profound caution and ensure that medication is reserved for situations of clear, unavoidable necessity after less invasive, supportive measures have been thoroughly pursued. Our primary duty is to safeguard the developmental potential of every child.
To conclude, while I echo the call for caution and comprehensive care, I must reiterate that psychiatric medications are indispensable, evidence-based tools for alleviating profound suffering in children with specific, severe psychiatric disorders. Appropriate use is not haphazard. It involves meticulous diagnosis, integration into multimodal treatment plans including therapy, and diligent monitoring by qualified professionals. Overly restrictive policies, born from fear rather than balanced evidence, risk creating insurmountable barriers to essential care. This would disproportionately harm children with conditions like psychosis, severe bipolar disorder, or crippling anxiety, potentially leading to devastating, irreversible outcomes including academic failure, social marginalization, and, tragically, loss of life. Our focus should be on facilitating sound clinical judgment, improving equitable access to all necessary treatments, both therapy and medication, and vigorously combating the stigma that prevents families from seeking help, rather than erecting new obstacles.
Dr. Reed, Dr. Carter, thank you both for an exceptionally insightful and forthright discussion on this profoundly important topic. You've illuminated the complexities, highlighting both the critical need for caution and the undeniable necessity of effective treatment options for children in distress. We hope this conversation encourages our viewers to reflect on the many facets involved. Thank you for joining us. Good evening.